Good morning, everyone. Welcome to another edition of the AVPA and Sankalp Dialogues, partnering to crush the curve. This is the sixth in the series, and the title of today's session is Access to Affordable and Adequate Healthcare for COVID-19 Patients. Again, welcome. As you're joining us from wherever you are, please use the chat box below to tell us where you're coming from, the area that you're dialing in from this morning or afternoon, depending on where you are in the world. Good morning, thanks for joining. And without further ado, I'll turn it over to our CEO, Dr. Frank Aswani.
Thank you, Toyin, and welcome everyone. Wherever you are dialing in from, whether you're in Africa, whether you're out of Africa, welcome. This is a continued series of the webinars that we've been having, as Toyin has mentioned. I'm really grateful to have hosted 6 so far in partnership with Sankalp, and Ariel and the team, thank you so much for the cooperation and help in making this work. So as people come in, please put in details of where you're dialing in from, what you do, your interest in this particular topic. Would love to hear more about what you're doing, how you're coping, and how you're delivering services and value, and the challenges you're facing, what help you require, all those kind of things. So as for those of you joining us for the first time, welcome. For those of you who've been with us for the last couple of webinars, thank you for hanging out with us. We appreciate your presence and your time. As you can see, we are working with Sankalp. AVPA is a network of social investors who are looking to deploy financial and non-financial resources towards social issues on the continent. And this COVID crisis has been a testing time for the continent in many ways. We're seeing resources stretched to limits we've never imagined before. And this topic today is of particular importance because at the core of everything that is COVID linked is a healthcare crisis. And we want to hear from the current people who will be our guest speakers today on how they're coping to offer and provide healthcare services during this crisis. We've seen broadly Africa has faced either an economic or healthcare crisis through this challenge, and we're very keen to see what we can learn from each other. So without further ado, Toyin, back to you, and let's enjoy the session.
Thank you very much, Frank. So again, welcome those of you that are joining us. You're joining us at the right time because we're about to kick off our 6th series on access to affordable and adequate healthcare for COVID-19 patients. So here we go. The first speaker on our lineup, Dr. Kendra Njoku. Please. Dr. Kendra, over to you.
Yes, please. Okay. Sure. So good morning, good afternoon, good evening from wherever you're calling in the world. Thank you for joining us. Thank you for the opportunity to the host. I hope everyone is keeping safe. I know we're tired of hearing that, but that's the time we are in. And just heading straight into who MDoc is and how we've responded to COVID. Company that uses technology, behavioral science, quality improvement methodologies, and evidence-based practice to improve the well-being and health outcomes for the populations we serve. Next slide, please. In response to COVID, being a patient-centered, organization at its core, next slide, please. We've had a bundle of interventions we have rolled out. So first of all, people were confused if they suspected they had COVID or a loved one had COVID. And so what we did was on our already existing online directory of services, that is Pan-African for all the countries in Africa, we superimposed over 200 emergency hotlines and over 500 testing sites, isolation sites, treatment sites for 44, as of present, 44 African countries. And so we're updating this in real time every time. So people, once they go to NaviHealth, AI, the link, they would be able to put in their country and see the closest, the hotline to call and the closest testing sites to go to. With COVID also, there was really increased anxiety and depression, both among healthcare workers and amongst the citizens of the world. And there was also the need to continue to provide care for especially for the vulnerable groups, given how the shutdown affected the scaling down of routine care at the health facilities. And so we opened up free teleconsultations, for a 90-day period for anyone who had, who needed to talk to a health coach or a mental health nurse around depression and all that, or just routine care for their chronic disease. Under Project RICOM 3 that we partner with, we provide self-guidance and behavioral lifestyle modifications to pregnant women to reduce indirect causes of maternal mortality. Now with COVID, of course, the anxiety and questions around, my routine healthcare ANC class is not holding anymore. What does COVID mean for my pregnancy? And so we had virtual antenatal and postnatal care, through phone calls, through our web-based, through phone calls, through walking them through our web-based platform called Complete Health, where they could check in their health indices and have a coach call them up and discuss the meaning of that, and also just provide routine ANC and PNC, information while, they waited for their label. In the same vein as that, we also ramped up our teleeducation sessions. They used to hold monthly, but now hold 2 weekly for healthcare workers, discussing, bringing expert knowledge and discussing things around how COVID management, could affect their management of chronic diseases like hypertension, diabetes, obesity, and cancer and all that. We also opened up what we believe for the first time to using the ECHO platform, University of Mexico ECHO platform, opened up to pregnant women. And so this, pregnant women were able, and nursing mothers are able to join these live classes that I've been holding weekly to discuss, things around breastfeeding, how to keep safe when they go to the facility for labor, what to pack in their bags, just generally how to keep safe after the baby is born. Do they still have naming ceremonies and all that? So these has been happening, and we've seen, a lot of people join in globally. Kenya moms, moms from South Africa, Nigeria, and even outside Africa. We've also provided communication materials, very nice, user-friendly graphics, infographics, guidelines on what to do if you have a chronic disease and at risk for more severe COVID. Also, in response, we saw a lot of moms afraid of accessing care at the hospitals with all the news flying about, a pregnant woman went here and then she came back with symptoms. Did she get it at the hospital? Also, the healthcare workers saying we don't have enough PPEs. And so we started a crowdsourced fund drive to raise PPEs that with each PPE being able to potentially save 4 lives. So the PPEs in the mama delivery kits has PPEs for a doctor, a nurse, and the mom and the baby. So and that's going on, and we're looking at providing the first batch of these delivery kits within the week. Next slide, please. And so what are our learnings so far? It's just that when you're patient-centered, when you're responding to the needs of the people, when there's a need that you're responding to, a digital transformation in health in Africa can happen overnight. And so pre-COVID, we were like, digital health was not, really being respected as an option of care. And this is no way to say it will replace in-person care. But, is there a value? Can it be complementary? And we're like, we Africans, we want to see face-to-face. COVID has said that's not the case. people are reaching out over digital platforms to seek care. New models of care. Was it possible to think that, you know, a pregnant mom with, you know, secondary school certification would be able to go to the and join a Zoom call? You know, that has showed that, you know, teleeducation is possible for patients. In wrapping up, our you know, what could make us do better? Partnerships. We really pride ourselves on able to accelerate skills by partnering with other organizations. So we're very open to that. Next slide, please. And also funding to accelerate scale is also really important. And then if you know, if you're able to join in supporting for the PPEs, you know, you can go to www.mymdoc.com, you know, or reach out to me. My email is on the screen, or my Twitter account is on the screen, and we'll be able to get back to you. I can't end this without just thanking the partners we work with, partners like funders like MSD for Mothers, and partners like JPIGO, and other partners that we work with. Thank you so much.
Thank you, Dr. Kendra. Very insightful and valuable contribution that MDoc is providing, not just and around the world, in Africa and around the world, like you said, in terms of people that have been affected by your services and what you've been able to provide digitally. Thank you again, everyone, for joining. Please use the chat box to let us know where you're coming from, what your interest in this topic is, and again, any questions that you have, please put it in the chat box, because at the end, after we've listened to all the speakers, we'll be filled in questions then. So without further ado, we'll move on to our second speaker, Dr. Babayemi Oshinaike from the Lagos University Teaching Hospital.
Hi, can you hear me, Tony? Thank you very much. Welcome once again, everyone. Let me just give a backdrop. The Lagos University Teaching Hospital is one of the country's foremost tertiary center, situated in Lagos, which happens to be the commercial capital of the country. And being a teaching hospital, obviously, we add our own peculiarities and challenges in coping with the COVID-19 pandemic. Next slide, please. Next slide. And one of the pressing issues for us is that the COVID-19 pandemic really has brought to the fore the challenges people have in accessing healthcare even before the pandemic came on. And basically, most of our intervention as an institution have been focused on some of these key drivers of access to healthcare. And I've just placed there three cardinal groups of decision-making steps that limit or decide how well people can access healthcare. Decisions taken at the pre-hospital level, decisions taken at the hospital level, and obviously when patients leave the hospital, what are the avenues for them? Next slide, please. And so as a hospital, what have we done to address some of the issues? And I realized that one of the major key drivers on how well or how quickly people access health, especially in the COVID-19 pandemic, has to do with the level of information they have and the ability to make health-seeking decisions. And so what we've done at the back end, the community health department have adopted and are engaging with local council development areas in the state currently. And what this basically entails, before now, the medical students, as part of the community postings, were rostered to the rural and urban facilities to understudy healthcare delivery at the primary healthcare level. And before now, this just used to be a one-touch scenario where after the student's posting is over, really there's very little or no engagement with the primary healthcare facility. But with the COVID-19 pandemic, what we've done more as an institution is to adopt some of these local council development areas and are actively engaging with the medical officers of health and with the Ward Health Committee in those local governments. And what this has done for us is that it has given the people valuable access to information that they require to make decisions, to seek help early when it comes to their health, especially in the light of the COVID-19 pandemic. We've been able, through this medium, disabuse social cultural myth that some of them had at the onset of the COVID-19 pandemic as to the origin of the pandemic and what some of them need to be doing. And because the medical officer of health have direct access to our consultants in the community health department, it has also made transfer and engagement with us at the front end in the teaching hospital a lot easier. The other thing that we've introduced, which is quite interesting, is the phone-in services. Just as Dr. Kendra mentioned earlier on, we operate in a scenario where people prefer they rather come to the hospital than have a doctor speak to them over the phone. But COVID obviously has also shown that this is the way to go. And so our specialist clinic, because we had to scale them down because of the need for social distancing, we've introduced the phone-in services, and the specialist phone numbers are available on the hospital website, where already registered patients are called by the consultant, and new patients who are seeking to access health at our facility are directed to the website. You call the numbers on the website, and a specialist responds to you. And if there's a need for you to then come physically to the hospital, we then will direct you to do so. One of the best moment for us, I guess, with this pandemic is also the specialist response team. Now, one thing that we have to keep in view as a hospital is the fact that even though patients are being diagnosed with COVID-19, quite a number of them have existing health challenges. Quite a number of them are hypertensive, are diabetic, and quite a number of them also have other issues that the COVID-19 scenario then makes access to such specialist care almost impossible. And what we've done as a hospital is that once the patients come to us, access to the specialist care required has been done in such a way that you can still access the specialist required. And one of our success story is what we've done by in our perinatal units, where the obs and gynae, the pediatrician, the anesthetists, and the nurses, realizing that some of the COVID-19 patients were going to require surgical intervention, decided to scale up and decided to form a response team that has been involved in cesarean delivery of the patient requiring such assistance, and this has worked significantly for us. Just earlier this week, we had our fourth C-section, the delivery of a set of twins to a 22-year-old COVID positive mother. This was part of the myth that we had to rise up to as an institution to address and to confront head on. One thing that has also worked for us quite well during this pandemic to ensure access to healthcare is that quite a number of public and private individuals have partnered with us, especially in the provision of valuable resources like the PPEs. Government is doing its own parts locally, but obviously, as it is with the global scenario, having people partner with you is definitely a welcome scenario. Next slide, please. And so what have we learned? Obviously, one of the things that we learned that we are improving upon is understanding how to strengthen the primary healthcare level. Realize that the decision that the individuals will make to seek help in formal settings starts with the access that they have to information at the primary care level. And so our community health department is working actively at ensuring that we engage more, as I said earlier on, at the local council development area with the medical officer of health, with the health committee at the ward level, make information available to them, make case definition easier to understand, pass messages across to them in ways that they can understand, and as such, make it easier for these individuals not only to be enlightened, but also to own the responsibility about their health and how to respond during the COVID pandemic. The other thing that obviously we are looking at improving obviously is in the area of the phone-in services. How do we standardize the response across all the specialist units such that people get the same some significant degree of care and attention when they call in and do not feel shortchanged by the phone-in services. We're also looking at expanding the channels and the modes of communication Zoom, obviously, and other platforms have shown to us that it is possible for people to access healthcare while outside the hospital and still not lose significant touch with their caregivers. We're also looking at communicating to them at the grassroots level in ways that they understand. So the public health department are looking at doing grassroots rally and doing grassroots meetings with the people at that community level. Next slide, please. Now, what are the areas that we're looking at going forward with this pandemic? Obviously, as I said earlier on, telemedicine and phone services is one area that, as a teaching hospital, we were not used to before the COVID-19 pandemic, and we had to adapt. We had to adopt, and we had to adapt our processes to embrace. And therefore, going forward, this is one area, obviously, that we are open to people who have been in this process to help us streamline the process, expand it if possible to telemedicine, where people can be at their various locations and they can call in. Obviously, one of the challenges we've seen early on because is the fact that the phone-in services require that the patient has to pay. It's not a toll-free number. And so we're looking at area situation where people can actually call in and these numbers can be toll-free. And we believe that this obviously will improve the interest and will improve the ownership of the process by the people. And obviously, as I said, an expansion to being able to then face and see the patient and the patient's interface with their doctors as well. Retaining and training and retaining of manpower. We realize that, especially at the primary health care level, when these healthcare workers are trained, retaining them at that primary health care level that is at close proximity to the end users that require these services then becomes difficult, either because of accommodation in the facility or because of some other logistics. And so these are areas where we believe that donor agencies and partners can come in with the training and with provision of facilities to help keep the trained manpower. And lastly, obviously, is in the area of the provision of the PPE. This is one area where as a teaching hospital, the health care workers on the front line, who are the ones who have to day in, day out treat these patients, feel that more can still be done to ensure that that the safety is guaranteed while they come.
Dr. Labayemi, but if you can just wrap up in about 20 seconds so we can move on.
Yeah, that actually is my last slide, and I'm pretty much done now.
Thank you very much.
And this is the picture of our set of twins delivered by our specialist team in the course of this pandemic.
Fantastic. Thank you very much for your work in Luth and also, you know, out of all of this crisis, to have some inspiration come out of it with the delivery of the twins. So thank you. We're now going to move on to the audience poll to tell us what you think. Where's the poll question, please? All right. What do you think is the biggest barrier to getting access to healthcare? Please pick which answer goes with the one that you think is the biggest barrier. Healthcare affordability, lack of money, access to healthcare centers, proximity, lack of knowledge and information on healthcare, fear and social stigma associated with health issues. So which one do you think is the biggest barrier? Another 5 seconds, and then we'll get the results, please. Okay. Results? Wow. So 68% overwhelmingly believe that it's healthcare affordability, lack of money, and health insurance. That's the biggest barrier to getting access to healthcare. Thank you very much. So we're going to move on. As we mentioned, we have 4 good speakers this morning. So, and in the interest of time, we're going to move on to our next speaker from Access AVPA, Melissa Menke.
Hi, good morning, everyone. My name is Melissa, and I'm the founder of Access AVPA. We are a primary healthcare company that operates in Nairobi, and we run a network of clinics that we call Clinic 2.0. So essentially, our model is tech-enabled primary healthcare. We use technology to do all of the things that technology can gain us efficiencies in terms of driving down the cost of care and improving patient outcomes. Examples of that are having second opinion software available at our clinics, having telemedicine connect patients on site to remote specialists, having automation in the back end on repetitive healthcare operations, and having digital engagement strategies with our patients in between visits. We also incorporate elements of lean health into our model. So our clinics are about 1.5 times the size of a standard shipping container. And inside of that, we prioritize the use of rapid and digital diagnostics, shareable assets, connected clinics. So having one central lab, being able to serve the full network. And this model ultimately allows us to be able to treat over 90% of what drives people into our doors on site, and also achieve pretty compelling clinical results. So last year, 98% of the patients that we served in our slum-based microclinics told us that they felt better within 3 days of a visit. We maintained 98% stock availability for the entire year, in contrast to about 52% at the public sector. Our Net Promoter Score, which is a measure of patient satisfaction, was around 6 times the national average for healthcare providers in Kenya, and we achieved over 90% protocol adherence to best practice medical guidelines in our sites every single time. So, and where we've gotten today is we have a network of 17 clinics in 4 different counties in Kenya. Next slide, please. What we're working on with COVID is we've divided our response into 3 key response areas. We've have an emphasis on staying open safely. So making sure that our staff have PPEs, that we've reworked the entire patient flow. So our elderly and immunosuppressed patients come in first thing when they have the clinics to themselves. And we've done a variety of innovations around just keeping the network of 17 sites open and serving patients. We've also done a lot of work around patient education. So getting real information into people's hands. But what I'll zoom in on for today's presentation is the way that we've been thinking about telemedicine. I think this is a trend because I've heard both previous speakers mention this work. So what I'll kind of focus on and try to bring from our perspective is how we've gotten it to work in the ultra low income areas that we serve. So I should have mentioned that all 17 of our sites are located in informal settlements. So really focusing on people who are working casually or for themselves and earning between 200 and 500 shillings a day. So when we thought about how to build inclusive telemedicine for low income populations, the first thing we looked at is what sort of features would needed to be kind of added on to a conventional web and app-based telemedicine platform to facilitate that type of care. We've programmed in USSD integrations. We've programmed in M-Pesa prepay, and we've also worked on having a request for a doctor to call you back. So you can essentially ping our platform and get a phone call. We did our initial rollout with patients who were seeing us already for antenatal care, diabetes, and hypertension, because these are 3 groups where we have long-term kind of sticky relationships with, and the tech adoption was easier because we had more face-to-face contact to explain how things worked before we did our second rollout, which was to general population for teletriage. So how this looks and feels like for us in a kind of closed loop system is a patient can send a USSD request to go through a diabetes consult over the phone. One of our clinicians from the clinic that they would normally go to will call them back. They will do some lifestyle coaching. They'll talk through results. They'll talk about their condition over the phone. Medications might be adjusted based on that conversation, and they will then get an e-prescription sent to them, which they then have the option of paying with M-Pesa from their home. So really all they need to do is come to the clinic, show the confirmation, pick up meds, and be in and out within 30 seconds. Next slide, please. So some of the insights that we've learned, I think that one of the things that my team and I were reflecting on is one of the things we had in Kenya was a bit of the benefit of time. So from an operational perspective, getting to learn, in February from PPE shortages, from challenges of overwhelmed health systems, we were really able to plan our operations and felt like the rollout of protecting staff, protecting patients, and keeping things safe rolled out relatively well. One of the things that we were pleasantly surprised about was how COVID-19 for us has really accelerated certain types of partnerships, both with people who were looking to support our efforts, but also with innovative insurance companies and other organizations that were looking to build new products and also innovate their businesses the way that it sounds like all of us on this call are innovating ours. One of the things that I think is an important insight is while the medical response from our end was very controlled, the actual patient support side is something that needs a ton more investment in. The reality is that probably all of our patients right now need some sort of subsidy because they have a complete absence of a social safety net and are working casually, and many of them have lost or reduced work over the last 2 months. So we're certainly seeing a complete pinch. We're seeing our average spend per visit drop. And in the absence of really good partners, it's difficult for us to respond to that economic kind of these huge economic challenges completely on our own. So next slide, please, which kind of rolls into what we need. So one of the things we're really looking at is patient support partners. We have a program we've launched with Give Directly to do unconditional cash transfer. We've been really escalating our most vulnerable groups, such as our chronic care patients and our pregnant women and new mothers for these programs, and we'll continue to add more. But I think that will just be kind of scratching the surface of what's needed for the economic recovery. So we're looking at partners who can step up to help us make sure that babies continue to get immunized, women stay on family planning, and people who have either predictable medication routines or are coming in for emergency or acute care can continue to get the services they need. That really links in with number 2 on that side, which is health financing partners. We've already seen some really interesting creative partnerships around insurance and people coming to us, but that absolutely needs to be accelerated because the majority of the market is uninsured. And as everybody on the call knows, as we saw from the poll, we actually have, we all know that affordability in health financing is probably the biggest challenge we're facing right now. And then, of course, as an organization, we're looking for funding, and specifically very technical funding, because we want to continue to build out new features on our virtual care platform, but also be able to integrate this more and more with partners who want to be able to use the functionality that we've built as well. So thank you all, and I'll hand it back to you.
Thank you very much, Melissa. And again, another platform that's helping to provide access to people in terms of your digital for the prescriptions, and also for a platform that people can use for telemedicine and addressing patients' needs. At this point, again, want to encourage everyone to put your questions in the chat box as we're going to our last speaker for today, Dr. Steve Adudans from Hewatele.
Thank you. Hello, everyone. My name is Steve Adudans. I'm the CEO of Hewatele. Hewatele is a Swahili word for plentiful of air. And we're in the business of saving lives one breath at a time by setting up oxygen ecosystems that are sustainable, and through partnership models to ensure that oxygen is accessible at all levels of care. Oxygen still remains a challenge in sub-Saharan Africa and is almost 10 to 13 times much more expensive compared to the Western counterparts. In light of COVID-19, we are seeing that there is going to be a lot more work that is done to ensure that oxygen is made accessible, especially for facilities that have been set up as isolation centers. Hewatela is a public-private partnership model in Kenya that has set up 3 oxygen plants that are generating oxygen, distributing the oxygen through a milkman delivery model to facilities, and also coupling that with training for healthcare workers. Our main aim is to sort out 3 challenges, and that is access, affordability, and safety. For access is through a delivery model, and for affordability using a pressure swing adsorption technology, we cut down the cost of oxygen by at least 30%. And for safety, we equip healthcare workers with pulse oximetry training, and also we also give them training on how to prescribe patients who need oxygen. Now, our responses to COVID-19 are to support the prioritization of improving access to oxygen by helping the government to supplement that which most patients need, and that is affordable and high quality oxygen. We are also optimizing oxygen generation in our plants through the acquisition of more bottles or cylinders that we refill and distribute to facilities. Currently, we are supporting over 150 facilities across at least 20 counties in Kenya, improving the lives of at least 300,000 people. Each of our plants can serve a population of about 5 million. And this has cut down the monopoly that exists in much of sub-Saharan Africa. We also want to, we are improving the knowledge and changing the practice of the clinicians, because we know that 13% of clinicians are at risk of getting infected with COVID, and therefore educating them on personal protective equipment like donning and doffing of gowns and other PPEs is very important. And at the same time, we also equip them with those equipment. Lastly, is we are part of global and national advocacy platforms like the Every Breath accounts, where we are advocating for investment on homegrown and sustainable responses to COVID-19, especially when it comes to access to oxygen. Next slide, please. Now, we've learned a lot, even as we have been responding to COVID. One of the critical areas that we've learned is infection prevention and control, which cuts across actually from the health care perspective to the population level perspective. So ensuring that PPEs and the disinfection and sterilization protocols are disseminated is very important. And ensuring that also the population understands the prevention mechanisms that needs to be put. Now, oxygen administration also is critical, especially before intensive care. Now, we know that some patients actually need intensive care when they are at a critical stage, but oxygen remains an important drug just before they reach intensive care. A lot of the facilities right now that are taking care of the patients are equipped with intensive care facilities, and especially ventilation for those patients. And we are working with the facilities to ensure that oxygen is accessible for those who need ventilation. The government currently has entered into an agreement with the World Bank to purchase ventilators that are going to increase access to intensive care for patients who need ventilation in the country. Next slide, please. Now, what do we need to scale? I think there's more investment that is needed to ensure that oxygen is accessible at all levels of care. Right now, we are able to reach facilities that have some that have primary health care, but majorly majorly of the facilities that we're able to reach are the ones that at least do have some level of secondary care. So PPP models, we feel is a very, very feasible and sustainable model that can be replicated anywhere. Leasing models, especially for governments, can be very, very useful. The other thing is making oxygen safe. we need to increase training for equipping the healthcare workers, whether with the pulse oximeters or PPEs, and then also piping of facilities to ensure safe administration of oxygen. Oxygen still remains one of the drugs that can also be injurious, especially to babies who are less than 30 days. So therefore, ensuring that oxygen is made safe for babies as well as adults is very, very important. I think I'd be happy to ask you maybe to go to our website, hewatele.org, look at the work that we're doing so that at least we're able to interact with you. We can share some of the playbooks or things that we can be able to help other countries, other setups in sub-Saharan Africa to set up a sustainable oxygen generation ecosystem. Thank you. Over to you.
Thank you, Dr. Steve. And again, thank you for the work that you're doing to build up the oxygen ecosystem and what's needed for patients, not just now during COVID, but also, you know, throughout. This is an important, you know, area that needs to be strengthened and focused on, making sure that we have safe oxygen. So moving on to our audience question and answer session. What are some of the questions that you have for our speakers? Please put them in the chat box. We already have a few that we'll start off with, from Laura to Dr. Babayemi. What are the items for the PPEs needed at LASUTH, and average cost of the total PPEs needed per healthcare worker?
All right, thank you, Laura. One of the essential PPEs that we're looking at currently would be the N95 face mask, the face shield, the surgical gloves and surgical mask, and then the disposable aprons. On the average, I don't know which country you are operating, you're calling from, to be able to give you the currency denomination. But on the average, for each time a healthcare worker has to review a patient and add-on any of this facility, you'll be requiring close to about 20,000. That's in Nigerian naira, which would be an equivalent of about $50 US, thereabouts, per healthcare worker per use.
Yeah. Thank you. Okay. Moving on to the next question. This one is for Melissa. Can your e-prescriptions only be filled out at your pharmacies, or other pharmacies, can people go to other pharmacies and still be able to get their prescription filled?
They can be filled anywhere. It's just a normal prescription signed by a clinician or a physician.
Mm-hmm. All right, fantastic. Moving on to another question for Dr. Kendra. What are the contestants of the PPE mama delivery kits? What are inside the kits, I guess?
Okay, so I guess that means the content.
Yeah, content, so exactly.
For each kit, you have an isolation gown and a suit for one nurse and one doctor. We have the face shield and the N95 masks, and regular surgical masks and gloves. For the mom, you have face masks to cover at least one daily for a 3-day hospital stay, a hand sanitizer for the mom to maintain hygiene, as well as a swaddle blanket for the baby that has danger signs and safe practices to guide the mom on care for the baby.
Okay. So another question for Melissa. You mentioned partnerships with insurance firms. Give us an example of how insurance is helping the most needy access healthcare through your platform.
So I guess maybe two things to highlight, and I saw something pop up later, so I'll also just be transparent. We still have around 90% of our patients paying cash, so this is definitely not tipped the scale for us in terms of having, you know, completely widespread uptake at the BOP. But two interesting things we've been working on. One is with a group called Insurance for All. And what they've developed with us is a capitation model. So instead of having a fee-for-service model where a patient could use any in-network clinics, because our prices are so low, a patient can pay about 50% of the normal premium if they agree to use our current network of facilities. And now that that's grown a bit, it allows them to maybe have one near work, one near home. So that's been one way we've been thinking about it, is how can the private sector's use of capitation actually be able to then drive down premiums for low-income patients. That's with Insurance for All. Another thing that we're looking at, this isn't live though yet, is MyTorocco is looking at ways that we can essentially take an even more stripped down version of our telemed. So instead of having USSD lead to a phone call or a web consult, actually having it just lead into a simple chat. So it wouldn't have to be a call at one time, but being able to essentially ask a question to a clinician. And that will kind of help sort of triage and sort of sort people in terms of using the right level of care. I guess, that doesn't necessarily increase access instantly, but what it does do in the long term is help patients use the more appropriate level of the care system, which can drive down costs and premium kind of more in the medium term.
Okay. Thank you for that response. This is a question to Dr. Steve. Are there any measures taken to ensure that prices for medicines are reasonable, especially to the grassroots level? And in your case, it would be your focus on oxygen, obviously.
Yeah, thank you for your question. I think for the Kenya government, what they have done to ensure that at least the cost of healthcare is affordable, there is a National Health Insurance Fund that funds mothers who go to deliver, would-be mothers who go to deliver in facilities through what they call the Linda Mama initiative. This is as ensure that deliveries are made free of charge. Similarly, also lower level facilities are now being taken up through the Universal Health Coverage Initiative. That is a flagship pillar in the current administration in Kenya. And this includes up to the provision of life-saving oxygen. So the government is quite committed to ensuring that healthcare is affordable, especially for the bottom of the pyramid in Kenya.
Okay, fantastic, thank you. This is a question again, and to Dr. Kendra. Has there been any issues with digital and healthcare literacy as people are trying to use your platform?
Definitely, and so we've seen improvement. And so when people come, most people take smartphone use to be digital literacy, but many people have smartphones but don't know, just use the basic functions of it, don't use it to full capacity. And so our health coaches have had to, and our IT support team have had to have videos made, screenshots made that teach women how to access the digital health tools that we provide, as well as in-person coaching on calls, walking them through how to use their devices to access healthcare on our Complete Health platform. We have also seen that most times when at baseline we give people, questions around their thoughts, people tend to score themselves higher in their confidence about knowing what to do, efficacy, knowing what to do about their health to get good health care. But when we now come to chatting directly with them, either through our support groups, platforms, or individually, we notice that even the basic questions, like a woman doesn't understand what blood pressure means or what the normal value is. She just knows that it's checked regularly at the hospital. So we've seen digital and health literacy improve as we work with this cohort of members.
Thank you for that. This question is for Dr. Shinaike. Have you considered doing safe recycling of N95 respirators using plasma sterilizer? And would you consider the provision of the sterilizer on a PPP basis?
Okay, thank you very much. We actually use our N95 on a recycle basis, which means that once we give one to a healthcare worker, as part of trying to ensure that we don't run out of this stock, one is actually used, which is consistent with experience worldwide, for about 3 or 4 cycles before we then discard such. Using the particular use of plasma to recycle, we haven't looked into that, but we're open to it, and if you want to reach out and help us in that regard, why not? We'll be very open to it.
Okay, great. This question is for Melissa. Please confirm if all 17 mini clinics remain open, or if the telehealth service caters for, and if telehealth services center cater to the low-income clients. Do some of the clients pay cash, or they all register under community-based health insurance?
So we had, yeah, we had 19, we closed 2. So the 17 that we kept are staying open and staying open safely. The 2 that were closed were very low volume, so it was done kind of under that, for that reason. For the telemed, so what we've done is we've put differential pricing onto it. So if you access it through USSD, it's actually free, because our assumption is people who are choosing to use that's what we're marketing to our patients. That's kind of the flyers and messaging that are going up in the target groups in sort of low income, although of course we don't have any sort of income test on that. So that would just be a free phone call from a doctor. If you access our web-based platform or go through the app, then you would pay, and the payment is differentiated. So it's 300 shillings for a clinician, 600 for a physician, and 1,200 for a specialist. What groups have done to ease that, although this really more benefits formal workers, is groups have, we've signed up a couple of organizations under group pay models. So then the patient doesn't pay, but the employer is billed at the end of the month based on usage, and have also rolled out various coupon codes with partners, and are willing to do that with more partners. If they would take on some of the marketing costs, then they can get up to 66% off for the people that they onboard onto the system for us.
Are the clinics 24 hours? Open 24 hours?
No, so we, under normal operations, we did 11 hours a day, and actually because of curfew, we're needing to close between 6 and 6:30 depending on the site. Partially just because that's then what makes even though our healthcare workers are technically exempt from curfew, it's so difficult for patients to move around after that time that we're just having to close to make everyone feel safer.
Great, okay. A combination question for Dr. Steve. How far down do you supply oxygen and do your training? Do you go down to the primary healthcare facilities? And also, can you tell us what has been done to make sure hospitals have ventilators, assuming that, obviously that COVID-19 patients would need oxygen?
Thank you for the question. Right now, we are in 3 counties that host the oxygen plants, and the oxygen plants serve facilities spanning across 20 counties out of the 47 in Kenya. For the host counties, we're able to go as far as almost primary healthcare level, because we have an agreement with the host county government to ensure uninterruptible oxygen supply for their facilities at an affordable cost. Now, that has enabled us at least to have a way to reduce our overheads, because they're able to ensure that we have access to some of these facilities, and they're able to make the orders. For the other counties, it depends on what they do want, but with our model, we're able to go down. How do we reduce our overheads for distribution? We have had to adopt an agency and depot model, where we set up depots for facilities that are quite far from where the oxygen generating plants are. And this is a model that is used by many logistic companies that distribute their products. So that has allowed us to reduce transport costs and reduce the cost of oxygen subsequently. In terms of intensive care, the government originally had what we call the managed equipment scheme, where they signed up with original equipment manufacturers, and in this case, ventilators, to set up at least, I think it was 11 ICUs. Now, we see the need to have more ICUs in Kenya because of COVID, and the government has already, brokered a deal with World Bank, and one of our good partners is going to be supporting the rollout of ventilators to the government facilities in order to ensure that patients do not have to travel long distances to access intensive care. So that is already ongoing, and the country should have more ventilators. On our part, as an oxygen generation and distribution partner, we are working with the government to ensure that they set up sustainable oxygen generation models for supporting these ventilators, because without oxygen, these ventilators will not be able to work effectively, and especially so not just oxygen, but high quality, high purity oxygen. So that is already ongoing, and there's conversation at the national and subnational levels. Thank you.
Thank you. This is a question to all the panelists as speakers today. And before we go in there, I'm looking at the time, and we have about 3 minutes. So to the audience and to the speakers, please, if you have the time, please stay on, because we'll continue to field some of these questions. And this question definitely is a question that I think everyone is curious about. And that is, as you know, right now in all of Africa, we haven't seen the increase of a lot of overburden of the healthcare system with COVID-19 patients. Why is it that this has not happened? And are we, is the worst yet to come, or or is there something that's going on in Africa that's causing us to not have as much in terms of an overburdened healthcare system? We can start with Dr. Kendra, and then go in the order that you spoke.
Okay. I mean, my key thought around this would be, first of all, data and the testing capacity. And so the admissions or confirmed cases is really based on the testing capacity of the country or of the continent. And so if we check testing numbers as against other continents and the burden of disease, then we can begin to say, are our present numbers a true reflection of that? Also, in terms of deaths happening, we have many deaths that happen on the continent without a clear confirmed cause of death. So basically, I would say this is all based on has a reflection of the capacity of testing we're doing, and the clarity around our data systems, and apportioning, what is really a cause of death.
I'll just say in addition to that, also the fact that COVID-19 has basically also reflected the use of health services in Africa generally. Just as Dr. Kendra said, quite a number of people are dying outside of the mainstream established hospital setting that are not being captured. And you also have quite a number of deaths that were not even investigated. I mean, Nigeria comes to mind, quite a number of states having deaths that are not accounted for, and the cause of which we are not very sure about. And I think it also speaks to the fact that during this pandemic also, the use of the mainstream hospital system has somewhat also reduced, and people are actually turning towards quite a number of interesting options, from the religious setting to the other local means of seeking healthcare, and those would never come to the mainstream data to reflect the exact burden that we are having in this pandemic.
I think that it's, I can only echo what some of the previous speakers have said about data. I think another, reality is that in Kenya specifically, 77% of the COVID cases that have been identified were asymptomatic. So the reality is we probably do have a lot more, but potentially not a lot more incredibly severe cases. I know just, anecdotally from what we're seeing day to day in the clinics and the facilities we're running is, an about normal proportion of respiratory cases, but a lot more concern and fear for those. Only 2 cases out of the 8,000 a month we've been seeing have had the incredibly severe kind of abnormal respiratory symptoms that made us escalate it to national testing centers. So yeah, I think I would echo that we certainly have more in Kenya than has been recorded, but because of the asymptomatic nature of the majority of our cases, widespread testing, echoing the other speakers, is the only way that we will get that full picture, and that's certainly in our ministry's medium-term plans that they've published.
And I'll also just echo the previous speakers, what they've said. So I would say for Kenya, just like Melissa said, testing capacity is very important, and even Dr. Kendra has mentioned, we started out with a very, very weak testing capacity with long lead times and also turnaround times for the test results. So we most likely had a lot of asymptomatic patients or suspects who actually recovered and therefore was not reported. So with the testing capacity that right now is becoming much better, especially like now for Kenya, then we're seeing a rise in cases. Secondly, I think is also a social cultural thing of how epidemics like usually pan out in Africa. There is usually the fear to go to a facility because of patients maybe are dying at the facility. You've seen this with Ebola. So even for people who have the symptoms, they fear to go to the hospital to try and get a test. So they'd rather wait it out until maybe they feel that right now it's quite advanced, and that has led to a number of people who may go through the symptoms and recover without being confirmed as a test case. But lastly also is that as a continent, we watchfully waited as the rest of the continent was doing a number of things. So we started ramping up some of the preventive mechanisms like masks and all. And by the time we started getting an upsurge of cases, it was we were to some extent had spread out the information for the population to start taking measures, and therefore that has led to a bit of quite a bit of a control, which may be anecdotal and neither here or there, but has helped. Yeah.
So thank you all for that. We are 4 minutes after the hour. And just again, want to say that thank you everyone for staying on for another maybe 10 minutes or so to ask some more questions of our very good speakers this morning on this very, very important topic, access to affordable and adequate healthcare for COVID-19 patients. So at this point, I'm going to open it up to the audience. Please raise your hand if you have a question for any of our speakers at this point. While we're waiting for someone to raise their hand, maybe we could again ask any of the speakers to answer. Maybe Melissa, I'll call on you to answer this question. Looking at the telemedicine and the platform that you're using, how are you educating the public around the importance of not having face-to-face, because our culture is a face-to-face culture. And now that we're being forced to use technology, how's that changed your business?
Yeah, completely. And telemedicine was the one thing that even in very kind of smartphone heavy countries like the US was always called the last frontier in digital, and people just didn't use it. So I think that the first thing I'll say before I get into education is the reality is because, I think some of the other speakers have referenced this, because people are more nervous to go to health facilities because they don't want to contract COVID, you are seeing more natural demand. So our first few users were just actually Googling, telemedicine Kenya and finding the site that we've been running for this year. So there has been a little bit more organic demand. And I think that it's absolutely now is the time. For us, we kind of pivoted from using telemedicine as a second opinion service in clinics to only going direct to consumer during COVID. But others who have been doing direct to consumer for a while, I think we're all in a similar place of having the kind of sense of urgency that people feel to get remote care. So there's a bit more organic demand, I guess. So we rolled out in a phased launch, and the first way we launched telemed was through people who were coming to the clinic often anyways. So our diabetics, our hypertensives, our pregnant women, our new mothers. And so we actually used a face-to-face visit to onboard someone onto the digital platform. So saying, okay, your next visit is now scheduled through the mDoctari app, and this is how you access it. And if you don't want to use the app, then actually this is how you would get us to call you. So all of our first work was kind of high touch. The second thing we did in phase one is just to gauge people's willingness to interact with us online. We set up WhatsApp support groups. So this wasn't medical consultations, no prescriptions were shared, but it was just an opt-in for again, these same three groups. To see who would actually opt in. And that gave us a proxy for who's willing to interact with us online versus who are we going to need to use this more kind of phone call based and an SMS based model for. And then we used WhatsApp for those who did opt in to then educate them about how to sign up. We're essentially just kind of entering phase two now. So it's sort of early days of us doing the rollout to all of our patients, not just these special groups. And what we're using is, first of all, digital marketing, which is, I guess if I'm honest, moderately effective for the market we're looking at in terms of kind of ultra low income, but decently effective in terms of reaching a slightly broader audience with our products and services. What we're looking at doing for people who then don't respond to digital marketing is actually still doing some high touch education. So hanging signs and flyers in the community, because even though we're on a quasi restricted movement scenario, everyone's out and about, buying fruits, buying vegetables in the community. So trying to have more posters, signs, and instructional visuals available in the areas that we're trying to target.
This last question, and then I noticed that no one is raising their hand, so I'm going to direct this last question. Thank you, Melissa, for that. To Dr. Oshinaike, around, again, looking at the Federal Teaching Hospital, LUTH, and, what are some of the interventions that the, government is doing to ensure that, with your institution, to ensure that there's affordable and adequate care for the COVID-19 patients?
Thank you. First, let me talk about the ones who are coming in to seek intervention first at the ER and at other points of entry to the hospital. One thing that we definitely stepped up to is the fact that COVID-19, as it is going to be with us for a while, and that most of the other health challenges must be looked at in the light of their merit and not just label the patient as COVID and then move away from the patient, which was what was the challenge we had at the onset of this pandemic, because the whole process of getting them tested and isolated for care in some stand-alone hospital was becoming an issue. And so what hospitals have had to do, and I speak from my local context, is that we've had to come to that reality that whether the patient is COVID positive or not, they have specific health needs. And those health needs must still be addressed. And so there is the increased sense of awareness in the teaching hospital community that the existing health challenges and comorbidities must be attended to. And so we're having quite a number of our frontline healthcare workers come to the table and making the decision that we are not going to have collateral deaths just because patients are COVID positive. And so there's that increased commitment. Secondly, the government has done its bit, and I must say that globally, every federal establishment is challenged with the enormous task of having to provide PPE. PPEs are being used up in a certain way that before now wasn't the usual pattern. And even when you have the fund accessing, being able to get the PPEs to your facility then becomes another challenge. And I know that this is one area that government and in my institution will be very open to public and private partnership, and quite a number of private donors coming to the table. The third part, which is quite instructive also, is that currently the health bill of the COVID-19 patients who are admitted in my facility are entirely taken by the government. In other words, every drug they use, the feeding and every other service that they require is actually borne currently by the government. No COVID-19 patient has had to pay a dime in my facility for any test run or for their meals or for the hospital stay. The government and through its partnership with donor agency has basically been responsible for that as well. And I guess that was also the government's way of encouraging people to come forward knowing that they will receive care at no cost to them.
Thank you very much. Just one last comment before we wrap up. From Timothy Adeboale had said that sincerely, we have not seen any sense of pandemic, respiratory distress, or unexplainable deaths in our community. These cannot be hidden, except we are talking about asymptomatic infections, not just about testing. It appears COVID-19 is behaving differently here. So if I may, I just want to ask Timothy to give a little bit of context around that comment, because that's a very interesting comment.
Hello?
Yes, we can hear you. Hello, Timothy.
Oh, good morning, everyone.
Good morning, go ahead.
Hello, good morning.
We can hear you, we can hear you, go ahead.
Okay, yes, yeah, trying to put context to my comment is, I mean, we don't have this feel. Yes, we've been hiding behind that. Maybe we're not testing enough people. That's why we're not having the numbers climbing. Yes, maybe we're talking about asymptomatic, but the way in our communities, there's no way you can hide some of these issues. Unexplainable deaths in community, if you're a community person, there's no way you have a feel. Something is going on. People are dying unexplainably. People are having respiratory distress, and they need to be rushed to hospitals. But that's not coming on in the mainstream ordinary community life, really, that we see. So there's still something about COVID-19 behaving differently here. Yes, with the hypothesis of environment and the sun and the humidity are there. So I think we're just fortunate because we don't have sufficient facilities to handle. So that's why it's staying in the places where they have sufficient facilities. So that's good for us, and we give place to go for that. So we can't just hide on the cover up by saying because we're not testing enough. I think we're not having the level of infectivity and the severity of the illness here in the Kenya is also, we're all in similar climates. So think that's the advantage I think we have over this COVID-19 issue. But except we have to wait and see what goes on. We don't expect anything worse really, but lucky us. Thank you.
Thank you for that context. A lot of people are responding though to your comments and saying that they're, well, in Nigeria, especially in the northern part, there's a lot more, you know, people dying, that there's, people are saying that it's related to COVID-19. But again, we need to continue to test and to get the data so that we would know whether or not these are just anecdotal or what have you. So at this point, I want to turn it over to our co-host for this session. Thank you very much for all of your great questions and comments. We'll continue to talk about this on all of our social platforms, the Twitter, Instagram, and thank you again for everyone participating and for staying over. So at this point, I'll turn it over to Ariel to do the closing remarks.
Thank you so much, Toyin, and thank you to all of our speakers. This was a really fruitful discussion, and to all of our participants and all of your comments and questions in the chat box to make this a dynamic conversation. We really appreciate it. We will be sharing the slides and the recording for everyone who is registered for the webinar, either later today or tomorrow, so you can look out for those and feel free to share them as widely as possible. And as Toyin mentioned, please do continue the conversation on Twitter as we move forward. We have been receiving some good news over the last few weeks about some partnerships and things that have been established thanks to these webinars. So if you have met people, established partnerships for your work that you think where in this webinar series played a role, please let us know. We would love to share the story with this community that we've built and with our global network. So please do let us know how things are going for you, if you're able to establish, any relationships or partnerships through this series. Our next webinar will be on June 4th, and the topic that we're looking at for that webinar is actually, Melissa alluded to it in her last few comments, around how we can improve access to information, particularly for informal settlements and low-income populations. Accurate information as it pertains to COVID-19. There's been a lot of misinformation that's been published and getting put out there. So we're really looking at what organizations are doing to ensure accurate information is out there. And we'll be sending out a very short survey after this webinar to you to get your thoughts and inputs on what's been helpful, what's not, how you would like us to continue these going forward. If you have new ideas for formats or structures, we welcome your ideas. So once again, thank you so much to all of the speakers. Thank you so much to all of the participants. And we wish you a wonderful afternoon, and stay healthy and stay safe.